Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program. And we're proud to be a community partner with Forward Radio WFMP 1065. Please join our radio family as a financial contributor if you can, or a volunteer. We're an all-volunteer community radio station. Go to forwardradio.org. And to learn more about Kentuckians for Single Payer Healthcare, please go to our website at kyhealthcare.org or follow the group on Facebook. Kay Tillow is the chair of Kentuckians for Single Payer Healthcare, and you can contact Kay at nursenpo@aol.com. That's nursenpo@aol.com. Single Payer Radio can be heard weekly now on Forward Radio. That's on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick us up on the airwaves, you can pick us up on your computer live by listening to the stream. Or you can go to the SoundCloud and pick us up in the archives. The views and opinions expressed on Single Payer Radio are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. We're recording today's show Wednesday, August the 26th, and this morning there are over 178,000 COVID-19 deaths in the U.S. Leading today's conversation, again, since earlier this spring, are retired surgeons and emeritus professors at U of L School of Medicine, Drs. Michael Flynn out of Louisville and Dr. Eugene Shively of Campbellsville, Kentucky. Dr. Flynn, Dr. Shively, what's on the agenda for today's show?
Mark, it's good to be here. We're going to talk about for-profit health insurance companies. Let me begin with the usual disclaimer that the views expressed here by me represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville.
My views represent my own personal views and not that of the University of Louisville and Department of Surgery, nor do they represent the Taylor Regional Hospital. I'd also like to say that some of the data is very fluid. It changes from day to day, and it can be challenged. This data is extremely difficult to come up with, and it's changing. And some of the data is kept secret on purpose to confuse the consumer. Some of the insurance companies make money by having data that's confusing, and this is very common in the pharmaceutical industry and the insurance industry.
Okay, so let's cut to the chase here. What I'd like to do is just make a few comments about why for-profit health insurance or investor-owned companies exist. Make a comment about how this country is a little different in the 1940s than it is now, and then Gene is going to go through a background of history of how we got from being a country that provided insurance to provide patient care to insurance to provide profits for insurance companies. So basically, a fundamental question: what is the purpose of a for-profit, investor-owned insurance company? Very simple. It's to make and keep as much money as possible. There's no secret about that. As Gene said, they have an assortment of ways to do this, and we're going to talk about that. We're going to talk about that today. Very quick comment. 1946, right after the end of World War II, Congress passed the Hill-Burton Act, which was a federal funding project for both public and non-public, non-profit healthcare institutions where they got grants and loans, with the understanding that they would provide health care to those who needed it and couldn't pay for it, and those that lived in the area. The result of this was an increase in the number of rural hospitals in this country, especially in the South. And since the 1980s, this has slowly eroded. Rural hospitals are closing, and health care is a real major issue in rural America, as Gene knows much better than I. So, Gene, tell us how we got here.
Well, it started in Dallas. There was a lot of people who were sick and didn't have a place to go. So a cattleman found a mansion that had 14 rooms. This was in 1903, and it was kind of the foundation for Baylor University. And they started hospitalizing people there. And then one of the vice presidents for Baylor University realized that some of the people had big debts because they were in the hospital. And this affected not only the amount of money they owed Baylor University, but also they had no money to live on. So he offered the Teachers Association in Dallas a kind of an insurance policy. You could pay 50 cents a month, and then if you had to go to the hospital, the first week you had to pay, but after that, the insurance provided $5 a day, and that covered the rest of your hospitalization up to 3 more weeks. And that concept grew. It later became Blue Cross. Then subsequently, when doctors got involved, he could get paid by Blue Shield. And up to 1939, through the Depression, there were about 3 million people who had some type of insurance. Now, during World War II and afterwards, there was price freezing. And so a company who wanted to hire someone couldn't hire them by offering them more salary, but they could offer them insurance. And from approximately 1940 up till the late 50s, the number of people with insurance increased from approximately 10% up to about 60%. The for-profit insurance companies realized that there could be money made in this, and Aetna and Cigna started also offering insurance. The difference was Aetna and Cigna picked the patients that they insured just like they would for life insurance. If you had coronary artery disease and diabetes, you had to pay lots more for life insurance, or you might not be able to get it. The same thing with health insurance, but Blue Cross Blue Shield accepted everyone, whether you had a pre-existing conditioning or not. And this did pretty well until the mid-90s. Now, it's also interesting that Blue Cross Blue Shield didn't have to pay taxes until there was a Congress passed an act in the 80s where they eventually had to pay taxes. And then by 1994, and I remember when this happened, I had Blue Cross Blue Shield insurance, and I got a letter one day that said that if you want to be part of our for-profit company, you could sell your shares. So I'm assuming that the Blue Cross Blue Shield I was in was a mutual company, and then they were transferring to a for-profit company, and I could have bought into that. I don't think I did. I kind of wish I had, but but I didn't. So what happened was that Blue Cross Blue Shield was taking on everyone, and they were hemorrhaging money. And one of the main reasons that various Blue Cross Blue Shield companies wanted to do this is so they could get into the stock market and make extra money. So they subsequently became for profit, and there are various Blue Cross Blue Shield companies around the United States. Each state had different companies, but there was an umbrella company that they had to talk into allowing them to go for profit. As they managed to go for profit, the emphasis changed from patient care and taking care of patients to taking care of stockholders and investors. And so we saw the amount of money going to patients changing from about 95% down to 80, or some of them went down to 60%. And with most of them, or a lot of the money, going to investors. This has progressed to what we see today, where most of the insurance companies in the United States are making a lot of money, and the investors are doing well, and the CEOs are making a huge amount of money.
Yeah, today we have over 1,000 for-profit health insurance companies, and they have anywhere from 15 to 30 different plans, which is an insanely complex system, which I hope we'll get into some of the details in a little bit. But let me tell two quick stories and then do something, and maybe we can talk a little bit about medical loss ratio. Now, I got interested in these for-profit health insurance companies about 25 years ago. I think I've told this story in an earlier program. I had taken a couple of skin cancers off an older gentleman who at that time was probably about my age. They'd come in the office. I was taking the stitches out, and he was sitting in a chair, and his wife was sitting over kind of across the room a little bit. It's a small room. And we were chatting, and she starts to cry. And I didn't think I was doing anything particularly difficult to, hurting her husband. And it turns out these people were from Western Kentucky. They had a rural business of farming. I don't know if they farmed fruit or pigs or exactly what it was, but it was something they'd spend their whole lives doing. Had a lot of other medical health problems, and they were about to go bankrupt. And they'd had this family farm. They were looking forward to passing it on to some of their family members. So, I mean, that's how I got started in this whole thing. I never did find out what happened to them, but it was it was terrible to listen to this poor woman cry. So that's kind of one kind of personal story. Second story, we talked a little bit about the Nixon, but one of the things that went on early in the lead up to Nixon's resignation were a series of stories in the Washington Post. They were written by a couple of reporters named Woodward and Bernstein. This fellow Woodward would meet with a source that the guy called Deep Throat in parking garages at night around Washington, D.C. It turned out many years later, decades later, that he was a high-level member of the FBI. And one of the first things he told Woodward was to follow the money. And so in a roundabout way, that's what I want to do right now, is follow the money. So, if you pay a premium to a for-profit health insurance company, it goes to a number of different sources. And as Jane has pointed out in one of our earlier programs, almost a third of the revenue in the healthcare in this country, I'm not going to call it a healthcare system because we really don't have a system. We have a healthcare, quote, marketplace, quote, unquote, whatever that represents. So you pay the premium and it goes to administrative costs. And we'll talk a little bit more about that in a bit. Advertising. We've talked to Dr. Kraus from Germany about the German system and Ted Young about the Canadian system. There's not a whole lot of that goes on. Political contributions. I don't think we asked either one of those two about that, but that's an important aspect of how and why for-profit health insurance companies exist. Executive compensation, which is outrageous, and we've got some of those numbers. Investor dividends. They make investments to make more money. And at the end of the day, when they pay the claims, they call this a medical loss ratio. Now, I mean, if there's anything that kind of gives you an insight into the mindset and the focus and the purpose of for-profit health insurance company, is that actually paying for health care is called medical loss ratio. As you said earlier, Gene, Blue Cross and Blue Shield had a 5% medical or administrative costs, and they spent 95% on paying for health care before they became for-profit. When they became for-profit, the administrative costs, which are all those things I just mentioned, ranged from 20 to 35%, depending upon whatever they could get away with in whatever market. And as you said, 80 to 65% of this was spent on health care, not 95%. Medicare currently has a 2% administrative cost. 2%, 98% of the money that goes through Medicare pays for health care. And in Taiwan, which has a national health insurance service, they actually pay less than 2% to cover the costs of health care in that country. So a lot of things to talk about. So where does the money go?
Well, under Obamacare, the ACA, part of that law is that at least 80% has to go for patient care. It's interesting that the other 20% is going for administration and for compensation to CEOs, etc. As we're set up right now, it's to the insurance company's profit that the cost of medicine goes up. For example, 20% of $100 million is less than 20% of $200 million. So if hospitals are charging more, even though they may not be reimbursed what they're charging, the cost for the insurance company goes up. And so they're making more money because the 20% is higher. The other thing that's happening is most insurance companies now are charging more for deductibles. Most companies who are paying for insurance are having large deductibles. For example, $5,000 deductible. Another trend, which we haven't heard much about, is that the insurance companies are talking companies into self-insuring. So you go into executives and say, we can offer you a policy for $20 to $30 per employee, and we'll take care of the administrative fee. But they don't tell you that the company's taking the risk. So if you have 100 employees and one of them gets an advanced cancer and has a big medical bill, then the insurance company is really only paying for the administrative charges, and the company is paying for the actual medical bill. So the next year, their premiums and their deductibles go up. A similar thing is happening with Medicare and Medicaid. More and more insurance companies are getting very interested in that because there's a lot of money. It used to be that Medicaid was run by the federal government, but state governments are now hiring for-profit insurance companies to administer Medicaid, and I think we're going to see the same thing happening with Medicare. Up through April of this year, the healthcare industry, most of which have been insurance companies, have spent $740 million lobbying the Democratic Party, and I'm sure that's dramatically increased since April, and probably this summer I'm sure it's dramatically gone up because of the Democratic convention, and they want to see a plan where if we extend Medicare and Medicaid, that they will get the option of administering those plans. One of the Democratic plans is to extend Medicare. So if we extend Medicare down to age 60, that means that the high-risk patients will be taken care of by Medicare, and that the insurance companies will have the less risk patients, and subsequently they will have less risk and make more money.
Let me just drop back a little bit to the sort of early issue, where does the money go? And this was a New York Times article in the Sunday Review from November of 2019. In 2018, the single quarter profits for 85 of the top publicly traded for-profit insurance companies, now there's 85, we got over 1,000 of them, was just under $50 billion. That's clear profit. So if you multiply that times 4, that's $200 billion that, I don't know, 8% of the insurance companies are taking out of the system. And the other, 915 for-profit insurance companies aren't even accounted for. Now, Gene, you talked a little bit about deductibles. One of the things I'd like to do is just go through the insanity of the complexity of what a person has to deal with if they get insurance from a for-profit insurance company. So you start off with a deductible. And this is why that poor woman was crying, because they couldn't figure out what was going on. So one, you have a deductible. That's an out-of-pocket cost that you pay before the insurance company pays. Problem is, it's very complicated, and it depends on the plan. So if you have a plan, before I retired, I had my health insurance from the University of Louisville, self-insured, and they, as you mentioned, they paid Humana, they paid Anthem, they paid somebody who would change every 2 or 3 years to manage the plan. But you've got a lot of people, so the premiums were relatively low, the deductibles were low, and the coverage was good. I have a friend out in Crested Butte, Colorado, who manages properties out there, and he has a small business consisting of himself and his wife, and they cover his son. I mean, he's got some insanely complicated system, and his premiums are high, and his deductible is $5,000 or $6,000 just before they pay for anything, just because it's just him and not 100,000 other people. So that's the deductibles. And then you have the copayment. So that's what you pay an amount for a service. And again, this is very complicated. And as you said, the complexity of this just makes people's heads spin. And it depends on the plan and depends on the service. So if you go to an emergency room or an urgent care center or get some physical therapy or get a prescription filled, you pay a copay that may be different depending on what the service is and depending on what the plan is. And then the copay may or may not go to your deductible, and after you've met your deductible, you may still get stuck with a copay. I mean, you can't win. I mean, and I'm just getting started here. So now we have this thing called surprise billing, okay? So this means that the institutions, the insurance companies they've negotiated with different providers to provide services at a certain level. And unfortunately, if you get a service from a provider who's not in the network, you get a bill. So let's say you fall off your bicycle and break something, or end up having to go to the emergency room and get a couple of x-rays, and the radiologist who reads the x-rays is not in the system, you're going to get a bill. If you have a hernia repair and the anesthesiologist is not in the system, you're going to get a bill. And you don't even know this. You go to the emergency room, you don't ask them, well, who's reading the radiology? And when you go get, I had a hernia repaired, I had my appendix removed. I mean, I knew who they were, but I don't know that if I'd not been a physician, I would have had sense to do this. Two more things.
Okay, sure.
Okay, yeah. Then you've got the issue of the premiums. And again, these things vary depending upon the plans. If you are a faculty member or a member of the University of Louisville, you have a low premium and a good plan. If you're a small business owner out in Crested Butte, Colorado, you have an outrageous premium and an outrageous deductible and outrageous co-payments if there's just the three of you. Allowed amount. Again, this is just the insane complexity. All of these little things just you make it so complicated that it's crazy trying to figure out. This is the amount that the insurance company is going to pay for that particular service, depending upon which plan you have. So you go to the ER visit, not only you have to deal with the copays, the deductibles, you got to figure out what they're going to pay for. Same thing with the hernia repair. And then last thing is coinsurance. So you've got all these other things to deal with, and then after you've met your deductible, you've got to get more insurance because depending upon your plan, let's say you had $1,500 of health expenses, you meet your deductible, but then your plan, again, maybe it's going to pay 70% of the additional costs, you get to pay 30%. A better plan, 80-20. So you've got deductibles, co-payments, surprise billing, premiums, allowed amounts, and coinsurance. There is no other industrialized country in the world that exploits its citizens like this.
Okay, let me just tell our listeners that this is Single Payer Radio on WFMP 106.5 in Louisville with Drs. Michael Flynn and Dr. Eugene Shively. And Dr. Flynn, let me just say that those profit numbers that you talked about, that was last year, correct?
That was
Last fall?
That was
No,
2018.
2018?
The article was in the New York Times in 2019.
Okay. Well, let me just say that I've seen some reports that during the pandemic, when people are afraid to go to the hospital or to the doctor, that those profits have skyrocketed even more.
Yes.
And like with some car insurance policies during the pandemic, you're getting at least some kind of minimal rebate
Yeah.
because you're not driving. Health insurance, well,
Hell no. These guys are laughing all the way to the bank. No, there's literally, you think about this, for I don't know how many months, there was no elective surgery.
right.
And that is a major, profit maker for hospitals, whether it's a for-profit hospital or a small rural, not-for-profit hospital. That's a biggie.
Right.
And with no elective surgery for a couple of months, that's a really, really big hit.
Well, and just before Dr. Shively comes back on, let me just say that I've also seen more reports that more and more middle income level families are forgoing health insurance because you get 12 to 20 grand a year for family policies, and more people are saying, I'm going to roll the dice. This isn't worth it. And then if they get hit, it's
terrible.
Katie bar the door. Dr. Shively?
Now, those health insurance companies are supposed either to decrease the premium or pay that money back. It will be very interesting if they do that. I can get you a job at the Courier Journal, and you can become an investigative reporter and find out if they really do. But by law, they have to pay that money back, and 80% is supposed to go to health care, and then they can keep 20%. So we'll see what happens. It will be very, very interesting.
Right.
Mike, tell me a little bit more about co-insurance. How does that work?
Well, as much as as well as I know about it, once you've got your, this is the Medicare, Medicaid, Medigap things that they tack on so that your 80% of your Medicare is paid for. 80% of a charge is if you have Medicare, then you have to take insurance to get the other 20% covered. I retired from the Navy Reserve after 20 years, so I'm covered by TRICARE for life. So it doesn't cost me, the amount of money that I have to pay in a copay or deductible is minimal. But the point that I wanted to make about the co-insurance is, I don't have enough personal experience with it, is the amount of complexity of these insurance plans that someone who is, someone works as a storekeeper somewhere or has a small business, and they have to deal with deductibles, co-payments, surprise billing, premiums, allowed amounts, co-insurance. That's why that poor woman cried, and that's the bankruptcy. Katie bar the door, Mark, is medical bankruptcy.
Yep.
And we have, in this country, 60% of bankruptcies are the result of medical issues. We talked with Ted Young about that, and there are two components to it. There's the medical costs, the bills, the insurance costs, the prescriptions, all of that stuff, and then there's the economic consequence of whatever the illness is, and the loss of work, loss of income. So it's kind of a double whammy in which you've lost money, or you don't have the money to cover all the costs of whatever health problem it is, and then if you've got one of those things that requires Just say you get in an automobile accident and you fracture your femur and you had a pneumothorax. They operate on you. You spend a couple of days in an ICU, a couple of days in the hospital, and you go into rehab. And depending upon what your occupation is, if you had to do something that involved walking, you probably can't work for 2 or 3 months, and that's a major issue. And I don't know if you remember when we talked to Ted Young about this. It doesn't exist. It doesn't exist in Canada. And when I looked up some data for an article that I wrote in Louisville Medicine a while ago, I found an article that indicated that there were zero medical-related bankruptcies in France in 2017. We were talking about kind of where does the money go, and one of the things I mentioned was the executive compensation. I mean, this is insane. So let me just read some salary benefits here. This goes back a ways. This is 2003. Now there's a guy named William McGuire who represents the all-time champion of CEO health insurance compensation. In 2003, they paid this guy $94 million and change. That's a 1-year salary, $94 million and change. The next guy below that, again, 2003, this is a while ago, Larry Glasscock, Anthem, $46 million. Just below that is WellPoint, which is what Blue Cross and Blue Shield used to be. It paid him $37 million. Down the bottom of the list there is Michael McCallum of Humana, getting $6 million. So that's 2003. So can't seem to get this to work.
Why do you think these guys deserve so much money?
Well, I don't think they deserve that much money, but they're getting it. I can't seem to get this.
You would think a surgeon like you who cuts people's neck halfway off would make as much money.
Okay, here's just a couple more, and then we can move on to something else. So we're at 2019, okay? 16 years later. United Healthcare, a guy named Alan Miller, gets $23 million. Again, this is a 1-year salary. This is not a golden parachute. This is not his life's work. This is a 1-year salary. And most of this money, not all of it, most of it comes from premiums that are paid with the expectation of getting health care coverage.
And that doesn't count stock options.
That's exactly right. They get a little money. They get money from their investments. They get money managing health care plans, like managing University of Louisville or whatever plans they manage. But the majority of the money that comes into for-profit insurance companies is from premiums. Okay, 2 more quick ones. HCA, they paid this guy $20 million, and then Cigna, a fellow named David Cordani, getting paid $18 million. And this is just the top guy. When you go down the whole food chain of executives in these insurance companies, the next guy down from this guy, Miller, was probably getting $18 million. So it's a huge amounts of money that have been extracted, and they're smart. They're smart business people, and they figured out back in the 90s that health care in this country was a soft target. And they figured out a way to exploit it, and they've really done a very good job in doing that. The end result of it is that we have probably some of the worst health care in the world in this country When you think about the fact that we've got 40 million people who are uninsured, 30 or 40 million people who are underinsured, and that's before the pandemic. I don't know what it is now. Those numbers are before the pandemic. We have medical bankruptcies of 200,000 to 800,000 a year, and all the people that have lost their jobs and that had health care because of where they worked don't have health insurance anymore, and they're trying to defund Medicaid and Medicare. So, I mean, it's a fascinating situation we're in from the standpoint of just taking care of people that every other first world country in the world has figured out a way to do this without wrecking their economy.
Well, I've had a little experience with Medicare. Now, I came on Medicare a little over a year ago, and Medicare pays about 80%. So you either got to go to an Advantage plan or get a supplement. And then, in addition to your supplement, you've got to get a private insurance for Part D, your prescription plan. And then if you want dental insurance or visual insurance, you got to get another insurance. Now,
You should have stayed in the Air Force.
I came very close to doing that. I would probably have to have a lot of insurance to take care of cirrhosis. But anyway, so you get a letter every month that tells you what these companies have paid, and then it tells you how much money you saved, and if you it's very difficult to figure out. I've actually spent some time trying to figure out if I actually save money or not, and it's extremely difficult. Like the supplement, Medicare will pay so much, and then they restrict how much the hospital or whatever or the doctor can pay, and then they pay a certain amount and they tell you what you owe. The pharmaceutical stuff is even much more complicated. And there are situations where you can go and buy a drug and pay cash and actually pay less. If you go out and buy a drug and the middle management, the pharmaceutical management company has done gotten a rebate from the drug company, and then they get a special deal from the company they're selling it to. For example, maybe it's Kroger, and so we get a very complex relationship. So it's possible that you can buy a drug and you can pay your copay, and your copay will actually pay for the cost of the drug, but all that extra money, the pharmacy benefit manager, the company, will make money off that. And it's for the patient or somebody who's even sophisticated, it's very difficult to figure out where the money's going. The Advantage plans can be also extremely complicated. What happens is that they say you buy a Medicare Advantage plan from Humana, you have to pay a premium. The federal government gives Humana some money, and it's very difficult to figure out how much money Humana's made and how much you're getting.
And there's more to it than that. My wife's mother lives in West Palm Beach, and she's got one of these Medicare plans. I'm not exactly sure what it's called. She had some problems with her eyes. Now, her daughter is an operating room nurse at the VA who does mostly ophthalmology. So she knows where to get a good ophthalmologist in town. So she wanted to have her come up here where she could get her in touch with, a really good ophthalmologist who would do a good job on her. Well, the plan that she has, not only with all the rest of the complexity, is limited to where she can get this stuff done. So it has to be done down in West Palm Beach. She can't come up to Louisville and get that additional coverage. Doesn't work. So and not only does that not work, but the way I understood it, even they had to bargain away the Medicare capabilities of getting health care here or somewhere else, as opposed to where she's located. So that they've got all these little things that they add on that limit your access to care depending upon where you are. This is a nightmare. Let me just, I want to, we are the only first world country that does this. We were in Italy a couple of years ago, and when you're in Italy, and you have dinner at night, you sit at a little small table that's right next to another little small table that's very close. And so you get to know the people that are eating next to you because you're almost sitting on their laps. And one night we were there, and we were talking with a couple from Australia. And one thing led to another, and we got around to healthcare. And these people were, they're obviously not poor people, or they wouldn't be in Italy from Australia, but they did okay. They were very comfortable. They were very happy with the system. It provided good care. They got a little bit of expense here and there. They didn't feel victimized. They didn't feel they had to have long waits. They were really very happy. So, all the Scandinavian countries, Belgium, Portugal, Germany, Switzerland, Singapore, Canada, Australia, New Zealand, Japan, Netherlands, Saudi Arabia. They call, every time somebody talks about trying to reform healthcare in this country, people start screaming about socialism. Well, Saudi Arabia, Dubai, and United Arab Emirates all have systems where they provide health care to their citizens, and I don't think any of these countries would be examples of raging socialism. So, why we happen to be one of literally the only industrialized first world country in the world that does this is really a terrible situation. I'm hopeful that the citizens of this country will recognize the opportunity they have with this upcoming election to do something about this.
Well, hopefully our listeners will gain some information and be able to distinguish between the scare tactics of whether it's insurance companies or different political folks who want to claim that expanding Medicare or providing coverage as a basic human right, it is socialism is thrown around on just about any issue right now. And Mike, I just had a question regarding your mother-in-law's policy. Now, if she would have an accident out of state, would her insurance cover that? Okay.
That's about the only thing it covered. So
Okay.
if you went out and something like that happened, but all of the other sort of elective aspects of health care, like going to an ophthalmologist in Louisville, was not covered. And not only, I could be wrong about this, but the way I understood it is that not only is the 20% copayment not covered, but the actual Medicare coverage isn't covered either, because that's negotiated away, as part of this process of accepting whatever this, I don't know what the name of the plan, Medigap, whatever the medical coverage plan is, but with all these other things, there's so many different options, and you pay this and you get that, and then you have to you get this 27-page thing that has very small print that you have to wear a magnifying glass to read. All of the restrictions and limitations and things that you have to deal with.
Okay, and,
Now-
and just go ahead, Dr. Shively.
This is an Advantage plan, correct? Medicare Advantage?
Yeah, something like that. Yes,
Okay.
I don't remember what it was. What it is a plan that's supposed to cover the component of Medicare that the component of Medicare doesn't coverage. So if 80%, it covers 80% of the cost of going to see an ophthalmologist in West Palm Beach, then this wraparound plan covers the other 20%. Or
Right.
covers most of it.
The Advantage plans restrict who you can see.
Yeah.
Okay. Just another comment on the issue about surprise billing. With these private equity firms buying more and more pieces of medical services and hospitals. I saw an article this morning, and it just said that first sentence in the article, hospitals owned by private equity firms rake in almost 30% more incomes than hospitals that aren't owned by private equity firms. And that was research that was published in the Journal of the American Medical Association, Internal Medicine. So I think it's going to get worse before it gets better.
That's when we did the follow the money thing. Isn't that what we said? I mean, can it get worse? It can. When you have the private equity and the hedge funds buying up practices, pharmacies, nursing homes, and whatever else they can get their hands on. A nightmare from hell.
The LifePoint, which is a large for-profit company headquarters in Nashville, and they have several hospitals in Kentucky, was recently bought by a private equity company. And they know nothing about health care. They're just, this is strictly for money. I think that's an extremely difficult and big problem. We're going from another level. We're going from for-profit to Wall Street.
Do we have time for me to tell one more story? Or
Sure.
we're too close.
No.
Okay, about 20 years ago, there was a surgeon in town who, toward the end of his career, ran for public office. And he was elected to the state legislature. I can't remember if he was elected as a senator or representative.
He was a representative.
You know what I'm talking about. And he gave a talk, a really good talk, at the Louisville Surgical Society. And again, we're going back to 2 or 3 decades almost. And a couple of things he said. He described the process of the political process as sausage making. I'm not going to go into that, but the point I wanted to make, the other thing he said was very frankly that the great majority of politicians don't understand health care at all. They really don't have any idea what's going on, and they're led around by the lobbyists. And that's what's really scary about what the potential for the future is, because it's not knowledgeable people making decisions about things that they understand. It's people who are sitting behind a desk and listening to some smooth-talking lobbyist who's getting paid a lot of money to give them some more money and then try to convince them to do something that's going to benefit whoever they're lobbying for.
I would surmise that most doctors don't understand what we're talking about today. We're not taught this in medical school, and you don't get taught this in residency. There's no time. I mean, medicine's so complex. You don't have time to learn this. And so we are in a very precarious situation. And we're being controlled by executives and the insurance companies and hospitals, for-profit and not-for-profit, who doctors don't understand this at all.
Hopefully, whoever's listening to us will take what we're saying and hopefully learn something from it. Again, we do have an opportunity, the citizens of this country, to change this, but they're going to have to go to the voting booths and do it, and they're going to have to try to understand what they want.
If anybody's interested in learning more about it, there's a couple of books that I've been reviewing. One is called The Great American Healthcare Scam. It's written by Dr. David Belk, B-E-L-K, M.D., and his brother, Dr. Paul Belk, a Ph.D., who does medical physics. And then there's another book called The American Sickness, which is written by Dr. Elizabeth Rosenthal. And she has gone into great detail about the American healthcare system, and it's a good resource for someone who is really interested.
Yes, sir. Guys, another hour or close to it has vanished. I just want to remind listeners that you're listening to Single Payer Radio here on Forward Radio, WFMP 106.5. And Single Payer Radio can be heard here on Forward Radio Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. We are a project of Kentuckians for Single Payer Healthcare. And to learn more about the group, you can go to kyhealthcare.org or follow the group on Facebook. And I think Harriet and Kay also have a Twitter account. And if you want to contact our chairperson, Kay Tillow, she can be reached at nursenpo@aol.com, nursenpo@aol.com. And we are, the group still meets the first and third Thursday each month virtually. So if you would like to join us on Zoom, send a note to Kay Tillow. She can get you on our list, as well as an invitation to our meetings. Doctors, any final thoughts?
No, it was an enjoyable hour, as usual, and look forward to doing it again.
Okay, Dr. Shively?
The health industry is extremely complicated. Part of the complications have been done on purpose so that for-profit companies can make more money. It's a shame that that's going on. We have to do something. We're spending 18% of our GNP on healthcare. That's more than the entire GNP of England and almost equal to the amount of GNP of Germany, which is the fifth largest economy in the entire world.
Okay, good deal. Dr. Shively, thanks for coming up from Campbellsville. And Dr. Flynn, have a nice trip back over to Cherokee Park. For single,
Thanks, Mark.
for Single Payer Radio, this is Mark McKinley. Thanks.